I don't think that the scientific community needs more evidence in favor of screening. The big issue is the implementation issue. The evidence is nowadays quite adamant. We have at least 2 randomized clinical trials in a population of heavy smokers, and both trials shows a significant decrease in lung cancer mortality of at least 20%, and in one trial even higher, and in women even more than 30 to 40%. In a number of those trials, there is also an improvement in overall mortality, so death by any cause. And in all the trials, we also see that there is a shift in the distribution of the stages of lung cancer at diagnosis. Well, it's not just the NLST and the Nelson, there's also the German Lucy trial and the Italian MILD trial that has published its mature results after 10 years. The main differences between the European trials and the US trial, the first one being that the control arm in the US trial is the chest X-ray, while in the European trials the control arm is no screen done. Another important difference is the handling of the nodules. One of the problems with the NLST trial was the high rate of false positive findings. In the Nelson trial and also in the other European trials, the nodule handling algorithm was changed. So instead of looking only at the diameter of the nodules, the investigators developed a nodule calculator which looked at the volume of the nodule. They reduced the number of false positive findings compared to the NLST trial and increased the sensitivity and the positive and negative predictive value of the trial. For the moment, at highest risk population, smokers and ex-smokers aged between 55 and 80 years, having smoked at least 30 pack year, and a pack year is an average of 20 to 25 cigarettes a day, and quit less than 15 years ago. In the US and in Canada, lung cancer screening has been advocated and is being implemented based on the advice and the guidelines from different scientific and public authorities. In Europe, there is still no consensus at the level of the authorities. Several scientific bodies in Europe have issued guidelines, have advocated screening. We still lack an agreement or guidelines from a number of societies, like the GPs, the general physicians. They still do not have advocated it. There are, I think, at least 10 hurdles to take before you can embark on it. Is it cost effective? This debate is still ongoing. So most probably lung cancer screening will be cost effective, but it hasn't been shown like the US has shown. There is a big issue on capacity. So will we be able to scan all those smokers? Do we have enough CT scan? Do we have enough radiologists? Do we have enough surgeons to operate? There is also an issue on safety. By exposing those participants to a yearly CT scan, do we not increase their risk on a secondary cancer elsewhere? This has been estimated and calculated several times, and although this risk is with the low dose of X-ray that is used very low, nevertheless, people are still afraid of being irradiated. I think, in view of the fact that for the moment, smokers and ex-smokers are the target population, those participants should be addressed by the GP and by the pulmonologist, and they should be convinced in advocating lung cancer screening in their patients. They have also the best data on the smoking habit. If you start screening only self-reported smokers and ex-smokers, you risk to have a bias on the smoking history, because obviously people who do not exactly fit the criteria will tend to exaggerate the smoking habit in order to be enrolled. The other problem is that by only relying on self-adhering participants, you risk missing the highest at-risk populations, being the difficult to reach blue-collar smoker. Who should address them? The medical community should address them.